Our third talk is on cautions and contraindications, and the speaker is Dr. Lakshmi ma'am. Ma'am is Professor Obs-Gynae in Malabar Medical College, Kozhikode, and she has been immediate past president of Calicut Obs-Gynae Society. We welcome you, ma'am.
Respected chairpersons, seniors, and dear friends, since the previous two speakers have already paved the way, a good introduction to the topic, I go straight into my topic, cautions and precautions in MHT. So before we start MHT, it's mandatory that we ask the 5 W's of MHT. So who is it for? What are the types and doses? When should it be started and stopped? Why is it so important to start? And where can you access MHT? So some of the initial few questions that we need to ask ourselves is the age of the patient, the years since menopause, the symptoms and its severity, the presence of comorbidities, the calculated risk for cardiovascular disease and breast cancer. So, coming to this very valid question, is this woman a candidate for MHT? So, we need to weigh the risks versus the benefits of symptom control, the skeletal benefit if it's there, the decreased CHD, incidence of CHD in a recently menopausal woman, breast cancer risk, and of course VTE, the stroke, the breast cancer risk with estrogen and progesterone, the importance of MHT in the presence of gallstones, etc. So one has to make a very individualized decision based on the risk versus benefits and also explore the possibilities of alternative treatment options, and it should be a shared decision making. So some of the known contraindications to MHT would be, definite contraindications would be known or suspected breast cancer, especially the estrogen-dependent malignancies, both endometrial as well as ovarian, any form of unexplained vaginal bleeding, active or past venous thromboembolism, known thrombophilias, recent myocardial infarction or stroke, active liver disease, porphyria cutanea tarda, which is aggravated with estrogen, as well as pregnancy. So always exercise caution when you have hypertriglyceridemia, even if it's a well-controlled hypertension or diabetes, active gallbladder disease, obesity or smoking, a strong family history of carcinoma breast, risk of cardiovascular disease, or migraine with aura. So why is caution essential in MHT? Of course, we know, as has already been discussed, it's the most effective treatment for vasomotor symptoms as well as genitourinary syndrome of menopause. Of course, it does provide bone protection and does improve the quality of life. However, risks vary based on age, timing, dose, route, and comorbidities. So the principle should be individualized therapy with a risk-benefit assessment. The window of opportunity has already been dealt with in detail, so I wouldn't go into the details, but just to put it in a sentence, the greatest benefit would be offered when initiated within 60 years or within 10 years of menopause, the reason being the presence of atherosclerotic plaques which have already been formed in the vessels, and estrogen being the most thrombogenic hormone will aggravate the incidence of thrombosis. So coming to the cardiovascular risk assessment, always go into the history of a recent MI or stroke when it's absolutely contraindicated. In an established coronary artery disease, avoid initiation, and higher risk if started over 60 and over 10 years of menopause. The first initial assessment should be the blood pressure, the BMI, the lipid profile, the diabetes, the level of control, smoking status of the woman. So estimate the 10-year atherosclerotic cardiovascular risk before initiation. Avoid systemic MHT in women with established CHD, and always prefer transdermal estrogen in moderate risk women. So the evidence statement, which is based on the European Society classification of cardiovascular risk, states that MHT should not be used for primary or secondary CVD prevention. Moderate CV risk, always prefer transdermal therapy. Venous thromboembolism, the risk factors to be considered would be a history of past VTE, obesity, thrombophilia, and immobility. Oral estrogen definitely increases VTE risk because of the first pass hepatic effect. So transdermal estrogen would be the preferred route. Previous unprovoked VTE, avoid MHT. In a recurrent VTE, it is contraindicated. Known thrombophilia, also contraindicated. And transdermal risk has a lower, transdermal estrogen has a lower VTE risk, but still to be used with caution. So the evidence statement says that oral estrogen increases VTE via hepatic first pass clotting factor activation. So in these instances, transdermal estrogen would be associated with lower VTE risk. Breast cancer increases with combined estrogen and progestogen therapy beyond 3 to 5 years. Estrogen-only therapy has lower risk. We all know the difference between the medroxyprogesterone acetate versus the natural progestogens like dydrogesterone and micronized progesterone, which have a lesser effect on breast cancer. Family history and breast density should be assessed by mammogram before we start. Systemic MHT is contraindicated. Avoid even in a remote history of CA breast. Non-hormonal therapy is ideally preferred. Vaginal estrogen, if required, to be given with expert consultation and ensure regular mammographic surveillance. Endometrial protection is conferred in unopposed estrogenic use. Endometrial unopposed estrogen increases the risk of endometrial hyperplasia and carcinoma, and this has already been discussed in the previous slide with the previous speaker. All women with uterus require adequate progestin. Investigate any abnormal uterine bleeding, and continuous combined regimen preferred immediately after 1 year of menopause. Unopposed estrogen should be contraindicated in women with uterus. So it increases the hyperplasia or carcinoma risk, but it's definitely said that at least 1 year of topical estrogen is not really going to increase the effect on endometrium, and thereby endometrial surveillance is not strictly recommended. Avoid oral estrogen in active liver disease. Oral route increases triglycerides and gallstone risk. Prefer transdermal route in metabolic or hepatic risk. Active hepatitis, severe cirrhosis, and abnormal LFT. Avoid oral estrogens. Neurological and stroke risk. Avoid initiation in women with prior stroke. Caution to be exercised in migraine with aura. Transdermal would be the preferred route in CV risk. Late initiation is associated with increased stroke risk. In migraine with aura, there is an increased stroke risk. Prefer low-dose transdermal estrogen. Avoid high-dose oral estrogen, and individualized risk assessment should be done. In diabetes and metabolic syndrome, it's not a definite contraindication in a well-controlled diabetes. Monitor glycemic control and lipids. Prefer transdermal estrogen in metabolic syndrome. Avoid oral estrogen in severe hypertriglyceridemia. And in uncontrolled blood pressure, delay MHT and start only if controlled and under strict monitoring. In special situations like fibroids, monitor for enlargement. Endometriosis, there's always a risk of reactivation, so continuous combined regimen would be better. In premature ovarian insufficiency, continue MHT until the natural age of menopause. In BRCA carriers, but with no cancer as yet, individualized counseling is required before the start of MHT, and a multidisciplinary approach should be undertaken in high-risk women. So, just to give a comparison between oral and transdermal estrogen, the first pass hepatic effect is not seen in transdermal. So in all these situations like VTA risk, hypertriglyceridemia, gallstones, CRP, increased CRP levels, the transdermal estrogen would be the preferred route of estrogen. And the risk-based route selection would be in obesity, metabolic syndrome, in migraine with aura, hypertriglyceridemia, past VTE, or stable diabetes. Again, the transdermal estrogen would be the preferred route. And in special situations, definitely one has to exercise caution. So what are some of the red flags which you should be on the lookout for? Sudden onset of recent chest pain or dyspnea, severe headache or visual disturbances, calf pain or swelling, unexplained vaginal bleeding, a breast lump. Review at 3 months and then annually, and reassess risk-benefit ratio yearly. So the key points would be to rule out breast cancer, VTE, and CAD risk before prescribing. A safer window would be less than 60 years or within 10 years of menopause. Transdermal route would be the preferred route in a good number of cases, and with absolute contraindications, which have already been mentioned, do not start. And with relative contraindications, always individualize. Thank you for your patient hearing.
Thank you. Thank you, Dr. Lakshmi, for your such a nice, very informative, clear-cut messages to everybody. What to prescribe, when to prescribe, and what are the comorbidities. I think that transdermal route is being increasingly used in nowadays. Any comment from the floor?
As far as route of estrogen is important, route of progesterone is also important. And you don't forget about Mirena, which also can be used. And it's not available here, but vaginal application of the progesterone is also available in Western countries.